Hello everyone, I would like to welcome you to stem cell transplantation rounds at Baylor College of Medicine and its affiliated hospital, Texas Children's Hospital and the Methodist Hospital. Today we're going to discuss two common infectious complications post-stem cell transplantation, and the title of the rounds is Monitoring and Managing Epstein-Barr virus and Adenovirus infection post-transplant. We're going to have four presentations. Dr. Lewis is going to present a case, and Dr. Heslop is going to discuss Epstein-Barr virus infection. And in the second part of the rounds, Dr. Kennedy-Nasser is going to present a case, and Dr. Bollard is going to present and discuss adenovirus infection post-stem cell transplantation. Dr. Lewis.
So I'm going to start by talking about the treatment of Epstein-Barr virus reactivation with EBV-specific cytotoxic T lymphocytes in a patient with X-linked lymphoproliferative disease. Initially, this was a 15-month-old male who presented to an outside hospital with fever and a diffuse rash. By hospital day number 9, he had developed acute liver failure of unclear etiology. After an extensive review of his family history, it was determined that there was a maternal uncle who had died at 4 years of age after an EBV infection. Autopsy evaluation proved that he had X-linked lymphoproliferative disease. Our genetics service was then consulted, and they identified a SLAM gene mutation in our patient consistent with the diagnosis of XLP. He was also diagnosed with viral-associated hemophagocytic syndrome with CNS involvement. At that time, he was consented to our open HLH-94 treatment protocol, including intrathecal methotrexate. He had blood procured for EBV-specific CTL generation prior to going on study, and it was recommended that he proceed onto stem cell transplantation for curative therapy. Within 4 months, he had had a 6-on-6 match-unrelated donor transplant. During his hospitalization, he developed engraftment syndrome that did respond appropriately to steroid therapy, and upon discharge, he was clinically well until day plus 60 post-transplant, when he was then admitted for sepsis and pneumonia. Prior to this admission, he had EBV DNA levels in his blood that were undetectable. However, soon thereafter, he developed an exponential rise in his EBV DNA. He was then consented to EBV-specific CTL infusion on day plus 90, and although there was a small increase in his EBV DNA levels afterwards, they appropriately responded to cytotoxic T-cell infusion and returned back to 0. He had 2 additional episodes of reactivation, one on day plus 254 and one on day plus 361, that were both self-limited and required no further therapy. Currently, he's 6 years old, now 4.5 years post-transplant, with no evidence of chronic GVHD. He has normal growth, although an advanced bone age that's being evaluated by our endocrine service, and is doing well in regular first-grade classes.
So I'm going to discuss how we monitor the risk of EBV infection in such high-risk patients and also manage this complication. Epstein-Barr virus is a latent gamma herpes virus that infects over 90% of the world's population. Primary infection usually presents as a lytic infection in the oropharynx, as shown in this slide, although can often be asymptomatic. After primary infection, the virus persists long-term in B cells as an episome where it escapes the immune system by only expressing a limited array of EBV antigens. This next slide just illustrates the processes during primary EBV infection where virus enters via the oropharynx. During this time, there's shedding in the saliva from epithelial cells and infection of naive B cells. These B cells can transform to 2 patterns of latency. Pattern 3, which is highly immunogenic, expressing a wide range of EBV-encoded antigens, such as the EBNA3s and LMP1, LMP2. In germinal centers, latency 2 is seen, where only LMP1 and LMP2 are expressed. These cells that are expressed during primary infection are then rapidly controlled by a very effective EBV-specific CTL response, which also targets lytically infected cells. And the virus only persists in the B-cell reservoir where cells express latency 1, expressing only EBNA1, so they're not easily seen by the immune system. So in a patient who's EBV seropositive, there may be occasional reactivations of EBV, where these memory cells which only express EBNA1 may reactivate to lytic infection, where you may get periodic shedding of EBV in the saliva, and occasionally there'll be reactivation to latency type 3. However, these cells will rapidly be eliminated by an EBV-specific CTL response. So to summarise, healthy individuals mount both a vigorous cellular and also humoral immune response to primary EBV infection. Antibodies neutralise virus infectivity, whereas a CTL response and also a CD4 response control both primary infection and reactivation from latency 1 EBV-infected cells. Now, normal seropositive individuals have high frequencies of EBV-specific T cells that persist long-term that target both lytic and latent antigens. And in most seropositive individuals, the frequency of EBV-reactive cells can be up to about 1 to even 5% in some individuals. So if latently infected B cells in the memory compartment either reactivate to become a type 3 latency lymphoblast or revert to the lytic cycle, they'll be rapidly eliminated. Now, EBV was also the first human virus that was implicated in oncogenesis, and it's associated with a heterogeneous group of malignant diseases. They really fall into two main categories. The first is in immunosuppressed individuals, where you can see EBV lymphoproliferation of type 3 latency, as is seen post-transplant, but is also seen in some individuals with primary or required immunodeficiency, such as HIV seropositive patients. The second group of malignancies is seen in immunocompetent individuals, and here the tumours express type 2 latency and include Hodgkin's lymphoma, some types of NHL, and nasopharyngeal cancer. This next slide just summarises the different types of malignancy and their pattern of latent gene expression. The most immunogenic malignancies, such as the post-transplant lymphomas we're talking about today, express type 3 latency, expressing all 9 latent cycle EBV antigens. These cells are highly immunogenic and are normally eradicated by an immune response targeting EBV. Type 2 latency tumours express a more restricted array of antigens, but can also be targeted via the LMP1 and LMP2 antigens, whereas type 1 latency malignancies are not so easily seen by the immune system, but EBNA1 may still serve as a target. Now, post-transplant lymphoproliferative disease occurs because of this long-term latency of EBV in memory cells and periodic reactivations. Normally these would be controlled by the CTL response, but in the setting of profound immunosuppression, impaired cellular immunity may allow the uncontrolled expansion of B cells, resulting in EBV lymphoproliferation. And this is really reflecting an imbalance between EBV-infected B cells and CTLs, which normally control reactivations. So in this slide, you can see that an individual may have a large number of normal B cells, and a small number of these memory B cells, shown here in purple, are going to express the EBV episome. Normally, when these undergo periodic reactivation to an infected blast, they're rapidly controlled by EBV-specific cytotoxic T cells. If, however, you've ablated your T cells by T cell depletion, or severely energize them by immunosuppression, these B cells, when they transform to type 3 latency blasts, may outgrow, causing an EBV-associated lymphoma. So when you think about this normal balance, this explains the risk factors for lymphoproliferation occurring after hematopoietic stem cell transplant. So particular risk factors are the degree of mismatch, with a higher incidence seen when there are greater than 2 mismatches, which usually reflects the more intensive immunosuppression these patients receive because of the greater alloreactivity. Selective T-cell depletion that removes T-cells without B-cells is another risk factor, as is underlying immune deficiency. If you look at several reports which describe the incidence of EBV lymphoproliferation after transplant, you can see that when you look at all allogeneic transplants together, the rate varies from less than 1% to a high of about 1.8%. So looking globally at transplants, it's not a very frequent complication. However, in some particular types of transplant, a much higher incidence has been reported. So in mismatch-related donors, where T-cell depletion is undertaken to prevent graft versus host disease, an incidence of between about 5 and 31% can be seen. A similar incidence is seen with unrelated donor transplants with selective T-cell depletion. If, however, you use campath depletion, the incidence is much lower at about 1.3%, and that is because you're also depleting the EBV-infected B cells as well as the T cells, so you don't have the same disruptive balance. Unrelated donor cord transplants overall have a low incidence at about 2%, again because there are very few EBV-positive B cells in this product. But there are a couple of recent reports shown in the last two lines of clinical scenarios where there are particularly high incidences. One is a regimen from Minnesota where they did non-myeloablative cord transplants using ATG in the conditioning regimen. And the second is a report from Great Ormond Street of a wide variety of non-myeloablative pediatric transplants, again with some T-cell depletion. And the reason here is likely that these non-myeloablative transplants allow the persistence of EBV-infected B cells in the recipient. Now, EBV lymphomas are very rare after autologous transplants, but there are some anecdotal reports after more intensive regimens. And a report a couple of years ago from COG showed an incidence of 3.5% in children who were undergoing sequential high-dose chemotherapy that was very intensive and likely depleting their EBV CTL response, and who then received CD34 selected peripheral blood stem cell transplants for neuroblastoma. And it's likely that lymphoproliferation can also occur after chemotherapy alone if the regimen is intensely T lymphodepleting. Now, the majority of lymphoproliferations occur during the first 6 to 12 months post-transplant, during the period of greatest immunocompromise. Lymphoproliferation can be seen later, but often in these cases it's EBV negative, and there may be additional genetic changes so that the treatment is different and more comparable to that of regular lymphomas. Post-transplant lymphoproliferation is a heterogeneous group of lymphoproliferative disorders. It can range from having a histologic appearance of reactive polyclonal hyperplasia to more aggressive high-grade non-Hodgkin's lymphoma. After hematopoietic stem cell transplant, it's usually donor-derived, but recently more recipient lymphomas have been seen after reduced intensity regimens, which allow the survival of EBV-infected cells deriving from the recipient. The clinical presentation can be very variable, and you need to have a high index of suspicion. It often presents with fevers and lymphadenopathy, but can also present with discrete nodules and sometimes with diffuse infiltration of organs, which can be much harder to diagnose. This slide shows occasionally you can get cells in the peripheral blood. More often they're found in tissues or at biopsy sites. The gold standard for diagnosis is biopsy of the affected organ, and this is important for several reasons. Firstly, you can confirm EBV positivity, which can be done either by LMP1 immunostaining or by looking for EBVs. The histology does affect the prognosis, so a high-grade lymphoma has a different outlook compared to a polyclonal lymphoproliferation. Immunophenotyping is important to determine if the CD20 expression, which gives you a therapeutic alternative in rituximab. And for later lymphomas, cytogenetics is important because that's going to change your treatment options. Many of these patients, though, we would prefer not to biopsy if possible, so a question that has come up has been, can EBV viral load predict lymphoproliferation in high-risk transplants? And in certain circumstances, can it allow you to make a diagnosis without the need for a biopsy? Most centres measure EBV viral load by using quantitative real-time PCR assays, but there are different sample types. Some centres use peripheral blood mononuclear cells, some use whole blood, and some use serum, and there are also different normal ranges. And the way the assay is done, the type of specimen that's used, and the particular laboratory normal range affect interpretation of these assays. So if you think what EBV viral load is measuring, if you're assaying peripheral blood mononuclear cells, it's going to measure a combination of EBV and normal B cells, which is latency 1 memory B cells expressing the EBV episome, or it's going to show EBV in transformed cells where you have type 3 latency cells which have outgrown. And obviously only the second type of cell is going to be predictive or associated with developing EBV lymphoma. If you consider what EBV viral load measures in serum, it measures viral shedding from epithelium and from lytically transformed B cells, which happens intermittently in normal seropositive individuals when there's reactivation to the lytic cycle. And it also measures virus released from necrotic transformed cells, which is a situation where a high load may be predictive of lymphoma. So interpreting both these assays, you've got to consider what is being measured. So we originally looked at EBV viral load as a predictor when we were evaluating high-risk patients who'd received a selectively T-cell depleted transplant from a matched unrelated donor or a mismatched family member. We used as our definition of a high load 2 consecutive levels of EBV DNA in peripheral blood mononuclear cells of above 4,000 copies per microgram of peripheral blood DNA. And in this patient population, the assay was both highly sensitive and specific for predicting and diagnosing lymphoma. However, when we used the same criteria to ask if we could predict LPD in all unrelated and mismatched transplant recipients, which included patients who did not receive T-cell depletion, here the technique remained with a very high sensitivity of 100% for predicting early PTLD, but the specificity was much lower at 50%. And this is probably reflecting the fact that a high EBV load may reflect type 3 latency EBV-infected B cells, which are predictive of LPD, but it may also reflect expanded type 0, 1 or 2 latency B cells in the normal memory population. And these cells may sometimes be increased post-transplant, but are not associated with the risk of transforming to lymphoma. So how might we improve the predictive value? One way that several groups have looked at is whether by assessing the EBV-specific immune response as well, the specificity can be improved. And there are several ways you can do this. One functional method that we used to use was looking at the outgrowth of EBV-infected B cells. This is highly specific, but the assay takes about 3 or 4 weeks, so it's not practical in most high-risk patients. A number of groups have looked at some rapid assays of global immune function, such as the immunoassay, which measures ATP release from CD3 cells after mitogenic stimulation. And another alternative is to look more specifically at the immune response to EBV by either tetramers or ELISpot. And basically most of these assays can improve the predictive ability, but obviously make the monitoring a more complex process. So how do we currently monitor for EBV PTLD? Well, we reserve our monitoring for high-risk patients, and in these patients we monitor EBV DNA either weekly, 2 weekly, or 4 weekly, depending on the time after transplant and the risk of the patient. If we detect an elevated level, this inspires us to monitor more frequently and to have a very low threshold for imaging if there are any other signs or symptoms of PTLD. If we can reduce immunosuppression if the patient is still on cyclosporin or steroids, we'll do that. And we will consider therapeutic intervention with anti-CD20 or T cells if there are any signs or symptoms of LPD. I think one of the challenging issues currently is when do you initiate treatment? Do you wait for biopsy-proven disease, or can you initiate treatment if you have a patient with high levels, a high-risk scenario, and a symptom such as fevers, which would be consistent? And I think the question of whether you use preemptive or prompt treatment is one which is still open for a final decision. So the therapeutic options, if you do have a patient with lymphoma or imminent lymphoma, are standard therapies such as chemotherapy or radiation and therapies targeting EBV. Most transplant centres now will start with therapies targeting EBV, which include antiviral agents, efforts that are directed at improving the T-cell response, so withdrawing immunosuppression or adoptively transferring T-cells, or approaches targeting EBV-positive B-cells. Now, reducing immunosuppression is normally first-line treatment in solid organ transplant patients, and in this setting it has greater efficacy in early disease, such as polyclonal hyperplasia, but less efficacy in seronegative patients. And in this setting, there's obviously a risk of rejection. It's not usually an option after hematopoietic stem cell transplant because of the more profound immunosuppression, so that you don't usually get enough recovery in a rapid enough time frame to get your desired therapeutic effect. It can be an option, though, in a patient with elevated EBV DNA alone and no other signs or symptoms of PTLD. The most commonly used approaches are now immunotherapy approaches targeting EBV-positive B cells. And these fall into two categories: approaches which target the B cell population, which usually means the use of rituximab, which is a CD20 antibody. With this approach, you're obviously going to deplete your CD20-positive EBV-infected B cells, but also normal B cells expressing this antigen. The other option is to adoptively transfer T cells, which are selectively going to deplete EBV-infected B cells, but not normal B cells. Now, there are several types of adoptive immunotherapy with T cells that have been used. Initially, the Sloan-Kettering group evaluated unmanipulated donor T cells, and subsequently we and other groups have evaluated donor-derived EBV-specific CTLs. More recently, Dorothy Crawford's group has evaluated whether you can use third-party, closely matched CTLs as an off-the-shelf product. Now, the rationale for using unmanipulated donor T cells is, as I mentioned previously, seropositive individuals have a high frequency of EBV-specific CTLs in peripheral blood, usually about 1% of all T cells. And the Sloan-Kettering group in their most recent update showed a very high response rate to unmanipulated T cells, which they used in recipients of matched transplants, and where they saw a complete response rate of 24 of 26 patients. But unfortunately, this population also has a high frequency of alloreactive cells, which is generally about a log higher than the frequency of EBV-specific CTLs, or even higher in a mismatch setting. So you also have a risk of graft versus host disease. So to administer a product that wasn't alloreactive, we derived an approach which we use for prophylaxis and therapy of generating EBV-specific T cells from the transplant donor. And to do this, we initially obtained blood from the donor, which was transformed with a laboratory strain of EBV to a lymphoblastoid cell line, which has the same phenotype and pattern of gene expression as type 3 latent C malignancies. These cells were then irradiated and used as stimulator cells to generate a CTL line under fairly standard conditions of feeding with antigen and expanding with IL-2. After the cells had passed all QA/QC testing, they could be adoptively transferred to the recipient. When we started these studies in the 1990s, we were doing selective T-cell depletion for patients receiving mismatched family member or unrelated donor transplants. And here we administered these cells in studies done initially at St Jude and then at Baylor to 91 high-risk recipients of such transplants who had a historic rate of developing EBV-LPD of 11.5%. And in contrast, none of the 91 patients on the prophylaxis study developed this complication. We also administered these cells to 7 patients who had not been enrolled on the prophylaxis study and who developed PTLD, and we obtained sustained complete responses in 6. And because we marked these cells in the initial 26 patients, we were able to show that in responding patients, they could traffic to sites of disease during a therapeutic response. Now, with the availability of rituximab, we're now restricting our prophylaxis studies to patients who are very high risk. And in this millennium, we've treated 13 such patients at Baylor and also at Great Ormond Street with Persis amrolia, who were considered to have a high risk of EBV because of the diagnosis of XLP, a past history of EBV lymphoma, or an EBV-positive malignancy. And these include patients such as the XLP patient that Dr. Lewis presented, and none of these patients who are high risk have developed LPD post-transplant with receiving CTLs prophylactically or preemptively when their EBV DNA level increased. We've also seen complete responses in patients with rituximab-resistant lymphoproliferation, and this observation has also been confirmed in a study from Patricia Camoli in Italy. So these T-cell approaches are obviously very effective, but they also are complex in the time taken to grow the T-cell product and the requirement for GMP facilities and operational infrastructure. So we currently reserve prophylaxis for high-risk patients with the diagnosis I mentioned previously, and we're also moving to use multivirus-specific T-cells, recognizing 3 antigens, rather than EBV-specific CTLs, to provide a broader protection in these immunosuppressed patients. Now, another possible solution is to have an off-the-shelf product of third-party CTLs from closely matched donors. And recently, Dorothy Crawford's group reported a phase 2 study in blood where they had a range of lines that could be sent to participating centres at short notice. And they reported a response rate in lymphoma occurring after solid organ or hematopoietic stem cell transplant of 64% at 5 weeks. There were higher response rates seen when the cells were more closely matched at least 3 antigens, and I think it's still an open question whether there's long-term persistence with these adoptively transferred cells and whether you might be at subsequent risk of viral evasion because you're targeting a more limited array of antigens. Now, the second type of immunotherapy targets B cells, and as I mentioned previously, is going to target both EBV-infected and normal B cells. Rituximab became available in the late 1990s, and in our initial studies using this treatment for PTLD, we treated 8 patients at Texas Children's, the majority of whom were following a mismatched or unrelated donor transplant. All responded, and 7 are long-term survivors. 1 later died of infection. This patient had also received ATG, but the rituximab may have also contributed to the immune deficiency. Very similar results have been seen in other series. This shows 4 series describing rituximab for hematopoietic stem cell transplant, and you can see the response rates vary between about 50 and 95%. There are some potential problems with CD20 therapy. It obviously induces profound B-cell depletion in patients who are already immunocompromised, increasing risk of infection with viruses such as CMV. You have the risk of selecting CD20 negative variants, and there's also a risk that you may lose EBV antigens, which will stimulate recovery of a T-cell response. Just to briefly go over other potential therapeutic modalities, chemotherapy is not used very commonly now for lymphoma after bone marrow transplant, but for patients who don't respond to immune modulation or rituximab, it remains an option. It's also an option for patients with cytogenetic abnormalities or with late EBV-negative lymphoproliferation. And standard regimens are used, although you may require dose reduction if the graft is not sturdy. Antiviral therapy has been used. This may have some value prophylactically as it will prevent viral shedding and infection of new target cells, but it's not going to affect the growth of latently infected B cells. The fact, though, that viral thymidine kinase is only expressed during the lytic cycle has been exploited in a strategy where the goal is to co-administer antiviral agents targeting the lytic cycle with agents that will induce lytic cycle genes. And the theory is here, if you give an agent such as Arginine Butyrate, which will upregulate lytic cycle genes, you can then come in with ganciclovir to activate thymidine kinase. And this approach was explored in a phase 1 clinical trial reported in Blood last year, where arginine butyrate was used to induce viral TK, followed by ganciclovir. This was explored in patients with a variety of EBV-associated malignancies, but there was a very impressive complete and partial response rate of 66%. Finally, there's been some reports that hydroxyurea may have activity in anecdotal case reports. The rationale for this agent is that persistent expression of EBV-encoded products is necessary for the growth of lymphomas, and hydroxyurea can eradicate extrachromosomal DNA elements. In the laboratory, it's very efficient at eradicating EBV episomes in Burkitt lymphoma lines, and there are several case reports of clinical responses in patients with EBV-positive lymphoma. So to summarise, the presence of EBV virus in post-transplant lymphoma offers prospects for therapeutic intervention with adoptive immunotherapy, vaccination, or small molecules. The most widely used therapies at present are rituximab to target EBV-infected B cells, or adoptive immunotherapy strategies to reconstitute the T-cell EBV-specific response. I think future directions are to define the optimum EBV PCR assays for monitoring, defining if immune function assays will increase the predictive value of these viral load assays, to determine if prompt or preemptive treatment is optimal, and then defining optimal treatment. So I'd now like to hand over to Dr. Alana Kennedy-Nasser, who's going to discuss a case of adenovirus infection.
Thank you. So initially, this was a 3-year-old male who had Down syndrome, who was diagnosed with AML in July of 2004, who received standard pediatric AML therapy. He suffered an isolated bone marrow relapse in August of 2005 while 8 months off therapy, and his disease was put back into remission after reinduction chemotherapy, during which time a donor search was formalized for a stem cell transplant. In November of 2005, he received a matched unrelated donor bone marrow transplant after conditioning with cytarabine, cyclophosphamide, total body irradiation, CAMPATH for in vivo T and B cell depletion, and GVHD prophylaxis consisting of prednisone and FK506. His transplant course was complicated by acute grade 1 GVHD of the skin and influenza A at day plus 92, from which he fully recovered. However, at day plus 133, he presented to the clinic with respiratory distress and hypoxia. It was found to have a right, middle, and lower lobe pneumonia. A bronchoalveolar lavage performed demonstrated adenovirus at 1,200 DNA copies per ml, and he required intubation with high-frequency oscillator ventilatory support, ionotropic support to maintain his blood pressure, and he was started on cidofovir. However, no clinical improvement was seen. At day plus 148, he received 5 × 10⁶ adenovirus-specific CTLs with complete resolution of his pneumonia, and at day plus 166, he was successfully extubated. This graph demonstrates a decrease in adenoviral DNA levels in the trachea after adenovirus-specific CTL infusion, with a corresponding rise in adenovirus-specific T cells seen in the peripheral blood. Clinically, the patient had no further episodes of adenoviral infections, and he's clinically well 2 years post-transplant. And I'll turn it over to Dr. Bollard.
So I'm going to give an overview of adenovirus infections after hematopoietic stem cell transplant. But first, a bit about background about adenovirus, which is a non-enveloped lytic DNA virus. It infects most animal species. There are 6 species and 51 serotypes, within which there are various clinical syndromes. Serotypes differ both in tissue specificity and virulence. So this table shows the various adenoviral species within which there are multiple serotypes. The serotypes that are coloured are the ones that are predominantly affecting our BMT patients, with species A being most prevalent in the stool and species C being most prevalent in both the stool and the blood. So the adenovirus can infect multiple tissues as shown here, and certainly the tissue tropism is dependent on the species which is being infected. So the three most common species in our patients are from A, B, and C, corresponding to gastrointestinal disturbances, hemorrhagic cystitis, and respiratory tract infections. So the normal immune response to adenovirus is a cellular and a humoral immune response. Adenovirus is not a latent virus, but we become multiply infected with adenovirus from childhood. We usually encounter adenovirus from species C during the childhood response, and our T-cell response at that time is usually very serotype specific. However, after multiple infections with adenovirus, by the time we reach adulthood, our CTL response is species cross-reactive. And given this importance on our T-cell immunity, it's not surprising that in the immune-suppressed populations that there's significant morbidity and mortality associated with this infection. So I want to just up front define the differences between adenovirus infection and adenovirus disease. So firstly, infection is defined as the isolation or detection of adenovirus at a single site. Our definition of disease is that we're isolating adenovirus at 2 or more sites in patients with symptoms. Disease can also be defined as patients with end organ damage secondary to adenovirus or culture positivity from the peripheral blood. The disease presentation is based on where the adenovirus is infecting. As I said, most commonly the adenovirus in our patient population infects the gastrointestinal tract. So diarrhea and gastroenteritis are the most common symptoms we see in our patients. So moving on to the incidence. This is highest in the pediatric allogeneic stem cell transplant recipients, with some groups reporting up to 41% of their population becoming infected with adenovirus. Adenovirus infection does appear to be the lowest in recipients of autologous stem cell transplants and also in adult patients after either allo or auto transplant. However, 20 to 70%, depending on the reports, of those who are infected will develop adenovirus disease. And in those with disease, up to 80% of those patients will die from adenovirus-related complications. As I said, adenovirus is not a latent infection, so many groups have asked what the source of the adenovirus is. Several groups, including our own, have looked for adenovirus DNA in the marrow donor product and have not been able to demonstrate its presence. So it appears that this is an unlikely cause of early adenovirus infection in our BMT patients. So more likely is that it's probably nosocomial origin. The risk factors for adenovirus infection in BMT patients have been looked at by several groups, and really it's, as I said, given the importance of the T-cell immune response in controlling adenovirus infection, it's hardly surprising that the risk factors are heightened depending on the degree of T-cell depletion in the patients. So patients who are recipients of haploidentical or cord blood transplants have a much higher rate, as do patients who have significant graft versus host disease. Other risk factors for actually adenovirus disease includes when you're isolating the virus from multiple sites, increasing your T-cell depletion using antibodies such as Campath, which is anti-CD52 antibody, or in patients where you're seeing a precipitously rise in viral load. So how are we diagnosing our patients with adenoviral infection? And the diagnostic tools available to us include indirect immunofluorescent antibody techniques, viral culture, and as shown here in this slide, immunohistochemistry and histology. However, viral culture is not always practical for monitoring and screening. It can take over 3 weeks to see the cytopathic effect and make the diagnosis. In the same way, pathological diagnoses are also not always practical, as it's not always possible to obtain biopsy samples from potential sites, and it's certainly not practical for monitoring or screening for early detection. So many groups have looked at the utility of PCR assay for screening and diagnosing adenovirus infection. However, the caveats to this are that there are false negatives, and as I will explain later, we're not sure of the positive predictive value of a positive PCR. It's important to know how your DNA is being extracted from the samples you're submitting to your lab, especially when you're dealing with stool or urine samples, which can become inactivated, in which the virus can become inactivated depending on the extraction technique used. Furthermore, when you're submitting blood samples for quantitative PCR, it's important not to use heparin tubes because, again, the PCR reaction can become inactivated. The first two groups to publish on the role of quantitative PCR are shown here. And the first group published a PCR assay using multiple primers and probes to span each species of adenovirus. Certainly this appeared to be a very sensitive assay, but was costly and complicated due to the multiple primers and probes required. So this led to another group developing consensus sequence and primers to cover all 51 serotypes in one reaction. So with the advent of these quantitative PCR assays, it was important to know what this would actually mean for the patient. And initially it was reported that the presence of adenovirus in the peripheral blood using this qPCR technique was predictive for the development of infectious complications. But many groups then went on to show that actually many bone marrow transplant patients are able to clear the adenovirus on their own. So several groups have now looked at this question, and it probably does indicate that a positive PCR value alone from the blood does not necessarily predict the development of disease. And really there is probably no direct correlation between viral load and the severity of symptoms. However, our group and others wanted to look further into if this would hold up with larger patient numbers. So what really are the better predictive factors using quantitative PCR? Well, certainly rising viral load rather than an absolute number in the blood does seem to be a predictive factor, with greater than a 10-fold increase over a relatively short period of time being predictive of fatal outcome. And certainly there may be a cutoff of a viral copy number that is significant, although at the moment what's published is quite a broad range between 1,500 and 20,000 copies. So should adenovirus-specific immune reconstitution as well as viral load be monitored in these patients to assess or detect the at-risk patients and limit the use of antiviral therapy? So our group and others firstly looked at whether we could just use the absolute lymphocyte count or the absolute CD4 and 8 counts to predict patients at risk. And all the studies so far have shown that these values alone are probably not going to help us predict our at-risk patients. So we and others have looked at correlating viral load with immune response in patients after bone marrow transplant. So I'm going to talk briefly about our response, our data where we looked at patients who were recipients of matched-related donor or matched unrelated donor or haploidentical grafts. And as you can see on this slide here, the greater the T-cell depletion, most obvious in the haploidentical recipients, the greater the immune suppression after transplant, and with our haploidentical patients not having immune reconstitution to adenovirus even at 12 months after a transplant. So the results from our studies were consistent with other groups, and we defined viremia as greater than 1,500 copies per mil in the peripheral blood. We did show that adenoviremia occurred earlier and viral load was higher in our MUD and haplo patients versus our matched related donor recipients. However, high viral load in the peripheral blood did not always coincide with the presence of symptoms and did not predict infection. And it was important to note that actually only the symptomatic patients went on to develop adenovirus disease. We also showed that patients with normal frequencies of adenovirus-specific T cells in their peripheral blood usually did clear the virus irrespective of adenoviral load. And there certainly was a correlation between viral load and the adenovirus-specific immune response or immune reconstitution for the development of adenovirus disease. So knowing now how to diagnose the patients, what are our treatment options for this group? Firstly, withdrawal of immunosuppression, with the rationale being that the importance of T-cell immunity to clear the virus means that any strategy that we can take to improve a patient's T-cell response to the adenovirus will be efficacious. However, there's an increased risk of adenoviral infection in patients with graft versus host disease, and so it's not always feasible to withdraw immune suppression in these patients. People have looked at the use of antiviral pharmacotherapy. There have been anecdotal case reports of efficacy using ribavirin, but there was no clinical benefits in a prospective study, even though it was a small study, and further work is needed to really look at the utility of this agent for adenoviral infection. What has become more promising is the use of cidofovir, which has been used by many centres. However, as far as published literature is concerned, there has been mixed responses in patients with adenoviral infection, which is more advanced. One group from St Jude did show a dramatic efficacy of cidofovir. However, the concern was in that study that many of the patients were being treated just for a positive PCR, and it is possible that these patients were being overtreated, since many patients will clear the adenovirus infection on their own. All reports, however, do state that antiviral agents are really not helpful for your patient with advanced end-stage disease, and really work is required for looking at this efficacy question using randomized studies. So finally, immunotherapeutic options include donor leukocyte infusion, allodepleted T cells, and antigen-specific T cells. This diagram shows the differences between the three different immunotherapeutic approaches. Starting from donor leukocyte infusion, where blood is taken directly from the donor, and the unmanipulated T cells are given back to the recipient. The concern with this approach is that, of course, there's a significant population of alloreactive T cells within that graft that you will be then transferring back to the recipient. The allodepletion method is attractive in that the T cells from the donor are incubated with antigen-presenting cells from the recipient, and then the activated or alloreactive T cells in the donor graft are then depleted, usually using an anti-CD25 antibody. Therefore, the final product that's transferred back to the patient is a multi-specific T cell population, which includes T cells specific for many viruses and is depleted of alloreactive T cells. The problem with this approach is that it does require that you have access to recipient cells to use in your mixed lymphocyte reaction during the manufacturing process, and this is often not feasible, especially when you're trying to treat a patient after transplant. Finally, the use of antigen-specific T cells relies on the use of an adenoviral antigen or whatever antigen you're wanting to stimulate your T cells with, and you use the antigen to infect the donor antigen-presenting cells to stimulate and expand donor-derived antigen-specific T cells. In this case, you're only giving the T cells for the particular antigen to which the T cells were stimulated against. So that's fine if you know which virus you're treating, but in patients with multiple viral infections, this may not cover the patient sufficiently. So some groups have looked at the use of unmanipulated donor T cells and shown efficacy, but with the caveat that the downside was graft versus host disease. Allo-depleted T cells, as I said, do require the recipient cells and are not always feasible, and although have shown efficacy, can also cause GVHD, possibly related to not as effective allo-depletion strategies as is practical. Looking at the antigen-specific T cells for adenovirus, the concern was which antigen would you use. In the United States, the use of adenoviral lysate would not get through the regulatory concerns expressed by the FDA. The use of overlapping peptides for adenoviral antigens such as hexon is certainly feasible but highly expensive. And so our group looked at exploring the use of the adenoviral vector, Ad5F35, which is predominantly the serotype adenovirus type 5, to try and stimulate adenovirus-specific T cells. However, the concern here is that would we actually be able to generate T cells that would be cross-reactive across adenovirus species? So in Europe, the German group were the first people to publish on the use of adenovirus-specific T cells for patients with adenoviral disease after transplant, and their strategy was to take peripheral blood mononuclear cells from the donor and infect them with adenoviral lysate, which they made from the Ad5 adenovirus serotype. Once T cells specific for adenovirus encountered the adenovirus-infected antigen-presenting cells, they started to secrete interferon gamma, and then the interferon gamma secreting cells were captured by an interferon gamma CD45 antibody. These cells, now labeled with the antibody, would then pass through a magnetic field and captured, and they're separated out, so only the adenovirus-specific gamma interferon secreting T cells were harvested and then infused to the patients. The group administered these T cells to 9 patients, and 4 of whom cleared the adenovirus after CTL infusion. All patients remained on cidofovir during that time, but as you can see here on this slide on the left-hand side, that only patients with a T cell response after T cell infusion were the ones that responded. Our group used a different strategy where we obtained peripheral blood mononuclear cells from the donor and generated activated monocytes and EBV transformed B cells, which were infected with the Ad5F35 vector. These cells were then used as antigen presenting cells to stimulate and expand adenovirus-specific T cells. As you can see on the slide to the right, our T cell lines had a significant population of adenovirus-specific T cells within the polyclonal T cell product. And we were able to show that in patients with adenovirus infection that we were able to clear the adenovirus from peripheral blood, and as shown here, we were also able to clear the virus from the stool, including adenovirus species from multiple subgroups. Finally, as Dr. Kennedy-Nasser showed, we were also able to clear adenovirus in patients with disease, as shown from her case history, where a patient received adenovirus-specific T cells and then within 2 weeks cleared the adenovirus from their trachea, which coincided with a rise in adenovirus-specific T cells in the peripheral blood. So to summarize our immunotherapy data, we and the German group showed that antigen-specific donor T cells were safe. We've treated 14 patients with T cells as prophylaxis and not seen any evidence of adenovirus infection after infusion, even though this is a high-risk group for adenoviral infection. 3 patients received CTL for adenovirus infection and all 3 responded. And we've infused 3 patients with CTL who had adenovirus disease, and 2 of the 3 were able to clear the virus, which is compared to 4 of 9 in the German study. So to summarize my last 3 slides, what are the practical considerations for the bone marrow transplanter who's facing the patient with adenoviral infection? So firstly, the conclusions about using PCR as a screening tool: it probably is not cost effective to use for screening of asymptomatic patients. And PCR value alone should not be predictive for symptomatic infection and should not be used as such. Secondly, how do we actually identify our high-risk patients? Well, in facilities where you do have access to assays which will assess your cell-mediated response to adenovirus, if you can interpret your PCR result in conjunction with your adenovirus-specific T cell immune response, this is highly predictive for identifying your high-risk patients. Alternatively, you can use adenoviral PCR positivity and interpret with the degree of T cell depletion the patients have had. So specifically the donor source, haploidentical recipients and cord blood recipients, and the type of T cell depletion used in the conditioning regimen, especially the use of Campath. Thirdly, it's important to look at the timing of adenoviral infection after transplant, with patients who become PCR positive early post-transplant having a much poorer prognosis. And then it's also important to keep screening these patients to look at the trend in viral load, as patients who have a precipitous increase in viral load are going to be higher risk for the development of disease. Finally, once you've identified your high-risk patients, how do you treat them? As we've shown, adenovirus-specific T cell recovery does correlate with viral clearance, so withdrawal of immune suppression should be started for your high-risk patients if this is feasible. The use of antiviral pharmacotherapy does appear to be the greatest benefit when started early for your high-risk patients in whom you've diagnosed adenoviral infection. And finally, immunotherapeutic strategies do appear safe and effective and should also be considered at institutions where this is available.